So there's always room for improvement, and we'll keep at it. The next scenario to talk about is a 56-year-old male who came to the GP. This particular patient had some chest pain. In the morning, he was sitting on the couch reading the newspaper, and the pain lasted about an hour. It was crushing pain down the chest, and it's central. 5 out of 10 radiate to the neck and jaw. Now, there's a storyline. The storyline is that this chest pain is not the first time. He had it last week while he was walking. It lasted 5 minutes. Yesterday was the second time, and he had this chest pain, and it lasted about 10 minutes. And he doesn't have any chest pain at the moment, but this morning he did. He was reading on the newspaper, and he had chest pain at rest. He does not want to go to hospital because his father died in hospital. His father had an MI at 67, and he died from it. He doesn't like hospitals, and that's obviously why he's reluctant to go to the hospital today. He feels that if he goes to the hospital, it may bring back memories about how his daddy died. So please negotiate and convince that this is really necessary. And if they don't want to go to hospital, at least they can go to the Rapid Access Chest Pain Clinic, which is a clinic not at the hospital. And they'll usually just do some investigations to make sure you haven't suffered from a heart attack, and obviously prescribe medications for the long run to help with the pain. The questions that you can find include, I really don't like hospitals. Why should I go? And they will eventually agree if you make them understand your viewpoint. But remember, they don't have to go to the hospital. They can go to the clinic. When will I see the specialist? You'll see the specialist urgently today. Good. Similar scenario, different onset. And again, the management is to make sure you know how to refer them to the right place and recognize the right symptoms. For the 57-year-old who came to the emergency with chest pain, again, it's 3 hours ago. The pain radiated, and the patient may still have the chest pain. What the key thing I need you guys to understand is, if somebody's having chest pain now, you need to act faster. You need to do your ECG, and you need to make sure that you call an ambulance if they're not in the GP. And if they are in the GP, that you do the investigations now. You make sure that you quickly do the ECG and things like that. Similar stories, similar risk factors, and obviously, he's worried he could have a heart attack. When you do your ECG, you can get a normal ECG, you can get ST elevation or T wave inversion. So here is a good idea of ST elevation. As you can see, it's not hard to miss. This one is in VL, okay? And you've got other areas, V2, V3, V4, 5. So pay attention. And no anterolateral, okay, AVL, V2, V3, V4, V5. This seems to be AVL. You've got some T wave inversions in AV foot here. And lead 3 is also positive. So you've got potentially also an inferior anterolateral, multiple areas. But the most part is to recognize the ST elevation and what it means. Good. So if we've got any questions at all for this initial part. Now, if we're dealing with DVT, the history of the presenting complaints could be leg pain or swelling. You may need to do a Socrates, an Odipara. Again, where is the pain? The usual questions. Can you point with one finger where the pain is? Was it sudden or gradual? Can you describe the pain? Does it go anywhere? Have you noticed anything that makes your pain worse? Have you noticed anything that makes your pain better? And is your, is your pain constant, or is it on and off? Does anything make your pain better? Does anything make your pain worse? And can you scale your pain 0 to 10, 0 being no pain, 1 being the least pain, and 10 being the worst pain you felt? In general, we want to make sure we rule out PE, any chest pain, any breathing problems, any coughing. And the leg symptoms themselves, you need to give a special focus. Because they've got leg swelling and pain, it's important you ask about color changes, if there's any bleeding, if there's any ulcerations, skin changes, or scars. And if the leg is pale, okay, that's color changes. And if it's cold, if they feel cramps, and we mentioned ulcers. So you've got leg pain, right? Swelling. So zoom out and think to yourself, my DDs will be things like cellulitis, My DDs will be things like acute limb ischemia and obviously PE from a DVT. Your past medical history will include varicose veins or any other problems with the legs, circulatory problems. Make sure you rule out high blood pressure. Make sure you rule out high blood sugar as well, and your general background history. Ask about any allergies, medications, as well as family history of any problems in the heart, clotting, or blood pressure. So personal and family histories. The job and the occupation and the travel will cover a few things. For example, a sedentary job, sitting down a lot, could be a risk factor. A long flight. Have you traveled abroad recently in the last 6 months? And if it's a female, you would have taken your contraception history and medications, and you would have gotten that as positive for COCP. Diet, exercise, smoking, and alcohol are fairly simple, and that shouldn't be a problem. And we will definitely use our communication tools. So when I was doing my simulation earlier, I didn't make enough use of those communication tools. And so again, another key area was, is there anyone who could be with you since I live alone? Anyway, ideas. Have you given any thought as to what could be causing your symptoms, concerns? Do you have any specific worries or problems and expectations? Is there anything at all you were hoping we could do for you today? You can probably do it at the end. Examination time and investigations. We do an examination of the chest, that's the heart and the lungs. We will also usually need to calculate what's known as a Wells score. Now, the calculation of the Wells score happens passively. Yes, B dimers are also other investigations to do, and as ultrasound gel scan of the legs also. But these, according to the guidelines, depend on the Wells score in terms of how you will go about it. Your Wells score requires 2 positive risk factors. The risk factors that we can talk about very obviously are going to be things like being immobile, having surgeries, having a active cancer, long flights, COCP. But some of them are going to be when you examine the leg. When you examine the leg, if the whole leg is swollen, if it's hot, if it's more than 3 centimeters in swelling, these are positive Wells score signs as well. You only need 2 for it to be highly likely. And usually, if it's not very likely, that doesn't mean you don't check. It just means that the first thing we might do may be a D dimer, or if it's highly likely, you may do an ultrasound scan of the leg, followed, obviously, by making sure you understand where you are. If you're in the GP, you do need to start the patient on apixaban at a therapeutic range so that once it's confirmed, they can continue. And if not, we can discontinue. So what's DVT? It's a clot in the leg, and it can be potentially dangerous. It can travel to your lungs, and it can cause problems. The main treatment is to thin out your blood so that the clots don't form. And so I'd like to refer you to the clinic so that they can do a gel scan, and we'll start you on some blood thinners. 6 months for those who don't have any provocations, and obviously 3 months if it's provoked. So make sure that you chunk and check and use your communication tools. And the follow-up will be with the DVT clinic. Safety netting will be chest pain, shortness of breath, pale leg, pain, pulseless, paralysis, numbness, and those are the 999s. Good. For your scenarios, I'll quickly open up the next one. For your pulmonary embolism cases, this is going to be very easy as well. We are doing a Socrates of any chest pain. We are doing a Foddy para of any shortness of breath. Your patient could have had sudden shortness of breath 4 hours ago, which is getting worse. And the patient is breathless right in front of you. So I need you to know what to do if you have a patient who is breathless in front of you. You need to prescribe oxygen. First, you need to do the observations. I can see that you're really short of breath. Okay, I'd like to quickly check your oxygen levels. And if the oxygen levels are low, then you need to give oxygen. That's right. So the patient developed chest pain 4 hours ago, along with shortness of breath, and the pain is really bad, is 8 out of 10, which means you do need to consider pain management as well. So this is an acute GP scenario. you need to do pre-hospital management before also arranging an admission. The way it goes is obviously, hello, my name is Dr. Radwan Ali. I'm one of the doctors here. Can I just confirm your full name and age? Yes, I'm Tom Smith and I'm 57 years of age. Okay, what can I call you? Call me Tom. But he's breathless as he's answering your questions. Look, I can see that you're really breathless at the moment. I just want to quickly hook you up to a monitor, check your oxygen levels and see what we can do. Oxygen levels come back as 90. And so you'll tell him your oxygen levels are quite low. You're really struggling to breathe. I'd like to give you some oxygen. I just want to ask, have you ever been diagnosed with having chronic obstructive pulmonary disease? Do you smoke? Give them the oxygen. They feel better. Okay. Now, can you just tell me what's been going on? I understand that you came in and I can see your shortness of breath. Can you tell me what happened or what's going on? Yeah, doctor, I've had shortness of breath and I've got this chest pain and it's been there for 4 hours. I'm really sorry to hear that. I just want to focus a bit on your shortness of breath that you mentioned. Did it start with the chest pain or was it starting separately? They all started at the same time, right? Okay. And you've been breathless since it started. Is that right? Yes, that's right. Okay. For your chest pain, can you just describe the chest pain? Where is it exactly? It's in my chest and it's a stabbing sharp pain, right? Does it go anywhere at all? No, it doesn't go anywhere. But I think it hurts more when I breathe in and it's really tough. Okay, I'm really sorry to hear that. Has your chest pain been constant as well? Yes, doctor, it's been constant. Have you noticed anything that makes your chest pain feel worse or better in any way? No, doctor, right. Can you scale the pain out of 10, where 10 is the worst pain and 1 is the least pain? Doctor, it's about 8 out of 10. That's really tough. We'll make sure that we give you some painkillers for that as well. I just want to quickly complete my assessment. We'll usually start you on some painkillers and increase the amount you need until your pain is controlled. Just a few questions about your general health, right? Because we want to know if they've had any risk factors. Now, if it's dull character, left side, things like that, it doesn't matter, but you need to make sure you cover your other DDs. So my first DD is PE. So I'm going to say, do you have any coughing? Are you coughing out blood at all? No, doctor, I've got no coughing. Have you ever had any pain in your calf? Have you ever been told that you have had a clot in your legs before? Do you have any high blood pressure, high blood sugar? Have you traveled abroad recently in the last 6 months? Okay. If it's a female, I will add a menstrual history. Otherwise, I go to past medical history. Do you have any past medical history? Have you ever been diagnosed with any medical conditions? Have you had any recent operations? Have you been immobile in any way? Are you able to move around? So this person may maybe a female, let's say. I know it says male here, but breast cancer is common in a female. So the past medical history of breast cancer, the patient is on chemotherapy, and that is a point for me in my Wells score. The patient also smokes 20 cigarettes a day for 20 years and is a diabetic, takes amlodipine for the hypertension as well, and is on diet. So you have multiple positive risk factors when you're doing your PMAF-TOSA all the way through to smoking, and cancer treatment is on chemotherapy. So how do we manage pulmonary embolism? We'll do the examinations, check the vital signs, okay? Listen to the chest, listen to the heart and lungs. We've already done our observations. The patient needs immediate admission, and so an ambulance needs to be called so that they can go to the A&E because it's life-threatening. From everything that you've told me and from the questions that I've asked you, unfortunately, I suspect that the cause of your symptoms could be a pulmonary embolism. This is a clot that has traveled to your lungs and is causing significant symptoms. I'm afraid to say that it is a medical emergency because it can be life-threatening. Is that clear so far? Now, I'd like to call an ambulance, and I can see you in significant amounts of pain. We'll make sure that we hook you up to a monitor, keep you on oxygen, as well as give you something for the pain. In the meantime, I think it's important we also start you on some blood thinners because there's a high probability that you have a pulmonary embolism. At the hospital, they're going to confirm it by doing a special test known as a CTPA. This is a special scan where an X-ray-like machine is connected to a computer and gives us an idea of this clot. If it's confirmed, you'll continue taking the blood thinners. Is that clear so far? Is there any problems at all? Well, doctor, I can't go. I can't go. Is there any particular reason why you can't go? I've got kids at home, okay? I've got kids at home. Or this one here, my husband brought me to the GP. Can he take me to the hospital? So let's answer that one, because the other one is very easy. I've got kids at home. Is there anyone at all that can help look after the children? Is there anyone you can call? No, doctor, there's no one I can call. That's fine. What we'll do is we'll go and we'll call the social services and arrange some temporary accommodation for your children and someone to look after while you receive treatment at the hospital, and they can come over with you as well. Is that okay? That's all right. Okay. In any case, the next one is usually going to be, my husband brought me to the GP doctor. Can he take me to the hospital? So you need to explain to your patient, Mrs. Johnson, the thing about a pulmonary embolism is, as you can see, it's causing very serious symptoms. And we've had to put you on oxygen. It's important you are closely monitored all the way through to the hospital. And taking public transport or going by car is not safe at the moment. It's best that you go via an ambulance, because they have the equipment to intervene if anything gets worse. I hope you understand. Your husband can come with you in the ambulance, and that should be fine. But it's important we wait for the ambulance and that we keep monitoring you until the ambulance arrives. Is that okay? So that's how you deal with such a scenario once again. Now, for those of you who are taking the full course, just remember, we're going to be sending you all of these things and you will be able to read up on them. And I want you to take the opportunity to do the visual learning and listen and take part as well. I do have the findings, for example, that you can find. Obviously, they'll give it to you like this. You need to quickly check, and you need to mention that your heart rate is quite fast, your oxygen levels are low, and you're breathing really fast as well, and then intervene. A quick rundown of another type of pulmonary embolism scenario is a 35 younger female. Her risk factors will change. If the older female was breast cancer that's active, the younger female will be taking COCP for the past 3 years, and she had a flight from Turkey 4 days ago. How will you manage this patient in secondary care is the question to ask yourself. That is correct. Sometimes the examiner himself may ask you, how will you manage this patient? So you should know your investigations in this scenario. You could get results, and the results will be O2 90%, as you can see, heart rate 110, and the usual respiratory rate will be high as well. So let's talk about the investigations to do. So we need to do an ECG. The finding is tachycardia. We do need to do an X-ray to rule out other causes. The echocardiogram is definitely going to help us assess for massive PE. The D-dimer is done usually when the PE well score is less than 4. I want you to know how easy it is to score on the PE well score. Because if the PE well score is more than 4 or 4, you need to do a CTPA. It is the investigation of choice, and it is diagnostic. For pregnant women, we would do a lower limb compression venous ultrasound scan, but let's focus on the CTPA as diagnostic for PE. The way I know to do the CTPA instead of a D-dimer is to quickly ask about the symptoms. If the symptoms are like that of a PE, which means the patient has no fever, and the patient has shortness of breath and chest pain, and it suddenly began, and they have risk factors such as COCP, immobility, a long flight, not breast cancer, but a cancer diagnosis and active treatment. These, plus having symptoms in the leg, which, like a DVT, make PE more likely. And so when another alternative diagnosis is less likely than PE, this already gives us 3 marks. Tachycardia of 110 is worth 1.5 marks. So it's very, very easy. From your history, it's likely, and another diagnosis is less likely. So you already have 3. You then need 1 risk factor, either COCP, immobility, and abnormal observations like a heart rate that's 110. That alone can tell you it's likely, which means that there is very much all the reasons for you, for the most part, to know that these PE scenarios will require CTPAs. If I'm speaking to the examiner, I have to be very, very clear. How will you manage this patient? My patient presented with shortness of breath and chest pain for the past 4 hours and had low oxygen levels. I will continue to monitor the patient. I will monitor the patient's ABCs. I will keep the patient on oxygen. I will give the patient pain relief as well. And I will ask for senior help. The patient will need a CTPA to confirm the diagnosis, as well as an ECG and chest X-ray. He may tell you, it's been ordered. Okay, I'd also like to do an echocardiography for the patient, and they'll say, okay, your echocardiogram has been ordered. Now you say, in the meantime, I would like to ensure that I start the patient on blood thinners because the CTPA may not be done immediately. So I'd like to order a CTPA, and if it can't be done immediately, I will start my patient on blood thinners. And so the guidelines say, start on the therapeutic range of anticoagulants that could potentially be continued once confirmed. That is apixaban. So I will start apixaban at a treatment dose. Now you need to also think about two other things that you may do. If the person had a past medical history of breast cancer and is not on chemotherapy, then you may need to do a CT of the abdomen, chest, and pelvis to look for potential recurrent cancer. But if there's already cancer, then there's already cancer. And for the patient who may have this, you need to look for family history of clots, because if family history of clots is positive, you may also look for hereditary conditions with clotting like thrombophilia. Give me a second so I can share the screen about the Q score. What is the Q score is important for us to understand as well. The Q score is a score that predicts the risk of someone, not predicts, it's dangerous to say predicts. It calculates someone's risk of having a major cardiovascular event, such as a heart attack or a stroke, okay, in the next 10 years. It estimates the risks of developing cardiovascular disease, which is disease of the blood vessels or the heart, in 10 years. If you're explaining this to a patient, we also want to manage our time. And if we're doing a consultation, there's a few things that we need to pay attention to. Mostly what we're paying attention to are P. maftosa. But we want to ask about symptoms to make sure the person hasn't had any heart attack or stroke-like symptoms. And so we're going to cover different areas. Let me walk you through the Q score. Usually, the person could be concerned. So history of the presenting issue. The patient could be concerned about stroke, could be concerned about vascular dementia, could be concerned about high cholesterol, could be concerned about heart problems. When we do counseling stations, we will talk about all of the different counseling ones, including concern about vascular dementia. We will also make sure in the masterclass, 3-day masterclass that we run as part of the full course, we talk about all the main ones and the high yield ones. So today it's more about making sure we discuss, learn, and that we do some simulations so that we can make sure we give you some guidance into how it would look like, and who knows, maybe you'll end up being better than me. So in any case, when we're doing the Q score, we want to ask the reasons as to why they came today. And when I show you the scenarios, you'll see yourself any relevant history, any concerns. I'm concerned about vascular dementia. Is there any particular reason why you're concerned about vascular dementia? Doctor, I came for a follow-up and they took my blood pressure. They took my weight against my height. Nobody's explained the results. So you're going to explain about the blood pressure. You're going to explain about the cholesterol levels or the BMI. And usually it is about explaining lifestyle. So if there's anything to ask about, it's about symptoms. Have you had any symptoms at all? If there's a specific symptom, take the specific history. Otherwise, you yourself need to ask the patient about any chest pain, any pain in the legs, any heart racing, any breathing issues. Have you noticed any weakness? So you're covering the heart, you're covering stroke, you're covering PE, and some of these other things that can present with breathing issues, leg pain there as well. Any weakness, face, any weakness in the arms, slurring of your speech, any vision problems, any memory problems, any headaches, any problems with walking. You will then make sure you pay attention to the cardiovascular risk factors in your P. maftosa. So you need to ask, any medical conditions such as high blood pressure, high blood sugar, okay? Ask about high cholesterol levels. Have you ever been told you have high cholesterol levels? Okay, and ask about any rashes. I need to tell you quickly, what are the usual things that you need to watch out for? Yes, family histories you need to watch out for. High cholesterol levels, high sugar problems, high blood pressure problems, so diabetes and high blood pressure as well. You also need to make sure that you cover atrial fibrillation. Again, you asked about heart racing, and so you covered atrial fibrillation, any heart racing, palpitations, and things like that. You ask about a rash because sometimes people can have psoriasis, which is an inflammatory condition, and it causes inflammation and rashes in the skin, but also inflammation in our body, which could cause damage to blood vessels. Okay, good. If you simply say, do you have any medical conditions? They will tell you about any comorbidities. Yes, doctor, I have diabetes. Or yes, doctor, I have rheumatoid arthritis. So these are open-ended and you're just listening. Now, scenario specific, we'll talk about later. But now we're just talking about how to do a cardiovascular risk assessment and understanding the Q score. In the exam, they will give you the Q score. It's not you who is calculating the Q score. The Q score has been designed by a company and they put together modifiable and non-modifiable risk factors to come up with the number. The number could be less than 10%. This is low risk. It could be moderate risk, between 10 and 20%, or it could be high risk, more than 20%. It's important you also tell the patient that doesn't mean you will 100% have a cardiovascular problem in the future. It just gives us an idea about the risks involved. And there are a few things that we can try to do to reduce those risks. And you start giving lifestyle advice, which is why another big area of this kind of consultation is to take a detailed history of someone's diet, exercise, smoking, and alcohol, including coffee as well, because coffee can increase blood pressure. For your communication tools in these kinds of scenarios, it's important to ask what's your biggest concern? Do you have any specific concerns or worries at the moment? Is there anything in particular you're hoping that I can explain and do for you today as part of this assessment? Examinations and investigations will definitely be the observations and checking the BMI. But you have to understand in these scenarios, they could have already done the observations. They could have already put the patient on an ambulatory blood pressure monitor, and today you have the results. It could be the BMI that was calculated, and they could already have given you the Q score. So you need to now explain those instead of doing those. So you could say, right, well, thank you for answering my questions. When you came last time, you had a measurement of your blood pressure done, you took it home with you, and it gave us an average blood pressure, which was 160 over something. And this means that on average, your blood pressure is quite high. As well as that, they measured your weight against your height, and it gave us a reading known as a BMI. Do you know what that is? A BMI is a calculation of how healthy your weight is. Usually the upper limit of a healthy weight is considered to be 24.9. Your reading was a score of 28, which means that your weight is on the higher side, and it can contribute to risks of developing heart problems or vessel problems in the future. Is that clear so far? So make sure that you're going through these things like that. I'm gonna simulate one myself, and hopefully this will give you a great idea. So again, we calculate according to age and other factors, and we calculate the score. Okay, is that clear? This score tells us for the Q score itself, the explanation. I think I did it before, but yes. When you explain that it calculates the risk of having, heart problems or strokes in the next 10 years, be sensitive and say, but that doesn't mean it will happen for sure. It just gives us a good idea about the risks and tells us if there is something we can do. And, having spoken to you today, I do want to suggest some lifestyle modifications, and I would like to suggest some medication as well. I just wanted to know, is there anything in particular you wanted to discuss? And is there, which one would you like to discuss first? There you go. Now here in the management, the lifestyle is about DESA advice, and the medication is usually statins for those whose Q score is, more than 10. So anybody who's around moderate risk to high risk, usually we suggest statins. We don't force the statins.
And there are weight management services, there are, health coaches, there are stop smoking cessation services, and all of these kinds of services that you need to offer once you've given the advice. Now, in terms of the lifestyle, motivation is important. Um, Motivation, telling the patient about the health and lifestyle benefits, as well as the dangers of a sedentary lifestyle. These are the kinds of approaches you may find. Sometimes it's enough to motivate them by telling them all the positives, and sometimes you may need to actually tell them the risks. And because we're already explaining the Q score, we're already explaining the risks. So we should focus on motivating on the positives. When when you exercise, your mood feels better as well. You feel better, you feel more confident, your concentration increases. I know in the beginning it can be tough, but there are so many services that can help, and they can be tailored to your needs. In terms of exercise, the advice is to usually have about 150 minutes of moderate intensity exercise in a week. This includes brisk walking until your heart rate goes up, but it can also include other activities that can make your heart rate slightly higher. And then 75 minutes of vigorous intensity exercise is also an option. This would probably be things like climbing up the stairs really fast, riding a bicycle really quickly, swimming. These really elevate your heart rate. And what happens when your heart rate elevates is that the circulation gets better, your blood pressure decreases, and you do feel better as well. Is that clear so far? So I'm going to try and do this in the 8 minutes that's required. And obviously, you do have that 8 minutes. It's important you involve the patient. So like Dr. Nida gave me the feedback earlier, I think it's important you don't sacrifice being patient-centered, and you don't focus only on ticking the boxes that you need to tick. And I think that the examiners and everybody is only looking to see how you approach it and how you began. You may not always have the time to finish. Don't worry about not having time to finish all the time, because that's not what it's only about. For your follow-ups in these Q-score stations, again, you follow them up in about 3 months. You would also follow them up for the results of routine bloods, including lipids and cholesterol, unless these have already been done. The safety netting will definitely be to watch out for signs and symptoms of heart problems and stroke, any chest pain, if you develop any sudden chest pain, okay, and if that's not going away, if you develop any slurring of your speech, any weakness, any paralysis anywhere, please make sure that you come back or that you call for help immediately. Good. So this is the Q score general, and now we go into Q score scenario related. When we're doing Q score scenario related, think well man, well woman clinics. This is where people of a certain age, I think it's if you're above 40, you generally, or above 50, I believe, you generally, yes, it's usually above 50, you generally should get checked up. So a man who's 50 years old came for follow-up at the GP. Other information that you have, he came last week and he had some blood tests done. He came last week and he had some blood tests done. The 24-hour ambulatory ECG that was done came back with an average BP of 165/95. The Q score is 16 and the BMI is 28. So I think Dr. Mariam is here to also take part in this. And I would ask Dr. Mariam to be my patient. And so I can then...
Hello,
Hello, Dr. Mariam. How are you?
I'm good. How are you?
I'm really good, thank you. So this is obviously where we are at for this one. I just want to ask you to simulate as the patient, and just give me a second here while I
Sure.
set up some of this stuff. We need to do it in 8 minutes. So can you just have a quick look at the PT info?
Yeah.
No?
All right. Just a second.
Yeah, so
Yeah.
got the timer there as well. So anyway, you came for a checkup, right?
My wife said
Yeah.
she get checked up. She got checked up as well, something like that, or my husband or whatever. Normally
Mhm.
fit in medications. But, you know, your job as a businessman, you know, you're not meeting your
Yeah.
targets. So life is stressing you out. We're adding a few things in there. We've got stressful life, always at the office, got no time for exercise, eats out, no time to cook or eat from home, smokes 26 a day, 18 years, drinks 2 glasses of wine a day, 2 kids and a wife. Will it, you know, you can choose to agree and disagree as to what you want.
All right.